Welcome all. So I will be sharing my screen. So I hope my screen is visible to everyone. So good afternoon everyone. I am Dr. Gaurav Deshmukh from Medical Services, Landmark Pharmaceuticals. Sorry. So I welcome you all to this webinar that is Belastin Expert Talk, and the topic for today's webinar is novel approach towards urticaria management. So, so before going into the introduction, I would like to ask Mr. Devjit Roy, who is a Senior General Manager, Derma Cluster, Glenmark Pharmaceutical, to share few words. Sir, over to you. Devjit, sir.
Thank you, Dr. Gaurav. So distinguished faculty members, delegates, and my fellow Glenmarkians, it's a great pleasure for me to welcome you all for this educational platform called as BET, Belastin Expert Talk. I am Devjit Roy, working at the capacity of Senior General Manager, Glenmark Dermatology. Today, we are fortunate enough to have very influential set of speakers across India to guide us through this session on urticaria management. We realize the fact that urticaria patients make up to a large portion of your clinical practice. Despite clear guidelines available globally as well as in India, there still remains to be a challenges in management of urticaria. Hence, we look beyond guidelines sometimes on expert opinion and knowledge. This session is designed to address the challenges of urticaria management with top faculties of India will be sharing their personal and real-world data in managing urticaria patients in clinical practice. In Glenmark, for last 43 years, we are passionate about one word called dermatology. And we always remain committed towards dermatologist fraternity, not only by providing innovative first-in-class products, but also unbiased educational platform like the one which we are having today, so that they can treat their patients better. So without taking much time, let me once again hand over the session back to Dr. Gaurav to start the session. Thank you so much, and most importantly, stay safe. Over to you, Dr. Gaurav.
Thank you, sir. Thank you for your welcome note. Now moving on to our program. So this is the brief agenda for today's meeting. As Dr. Mr. Devjit has already welcomed us, then this welcome note will be followed by the introduction of the moderator and the speaker. Now there will be two presentations in this during this program. One by Dr. Bilasha, who will be speaking on her real-world experience of Belastin in chronic spontaneous urticaria, while Dr. Abhishek Dey will be speaking on his experience of Belastin in refractory urticaria. Now, these two presentations will be followed by a panel discussion where the main discussion will happen on managing urticaria in COVID times. Now, the panelist for the moderator for this panel discussion is Dr. Abhishek Dey, and the panelist will be Dr. Bela Shah, Dr. Sushil Tahiani, sir, Dr. Arun Inamdar, Dr. Asit Mittal, and Dr. Anil Gandhi. And this panel discussion will be followed by vote of thanks, which will be presented by Mr. Parikshit Kurekar. So moving on to the introduction. So I would like to take this opportunity to introduce our moderator and speaker for the day. Now the moderator for today's meeting is Dr. Abhishek Dey. Dr. Abhishek Dey is Associate Professor, KNMC Medical College, Kolkata. He is Associate Editor of Indian Journal of Dermatology and Assistant Editor of JCAS. He is a member of SIG Lasers and Honorary Secretary of Skin Allergy Research Society. He has multiple publications to his name, more than 70 publications, and has 21 book chapters. He is the editor of Textbook of Lasers in Dermatology. He has multiple awards to his name, like Rising Star Award at WCD Vancouver, Vishnu Priya Devi Award for Best Original Article Award, Indian Journal of Dermatology Best Paper Award, Fellow of National Skin Center Singapore. He is a scholarship holder of American Academy of Dermatology, Then he's a member of ISD mentorship in Bangkok. He also has Professor B.N. Banerjee Award for Best Original Research, and then Professor Salil Panja Award for Excellence in Dermatology, IIDVL West Bengal, and also has a Best Orator Award from IIDVL Jharkhand. So with this, I welcome Dr. Abhishek Day to this meeting. So our speaker and the panelist for the day is Dr. Bela Shah. Now, Dr. Bela Shah is a professor and head of Department of Dermatology, STD and Leprosy, BJ Medical College and Civil Hospital, Ahmedabad. She has more than 30 years of experience in teaching, has doctoral research on PUHA and PUHA sole in psoriasis, has multiple research to his name like leprosy research, vaccines or newer drugs, HIV study of mucocutaneous manifestations with relevance to CD4 count. She has multiple achievements to her name like delivered talk on various subjects in multiple state and national conferences and multiple CMEs, presented paper at every national IDVL since last 20 years. She's author of multiple dermatological textbook, has 35 national and 4 international publications to her name. She has been invited as a guest speaker at 16th EADB Congress in Vienna in 2007. She has Dr. P.B. Hari Bhakti Oration Award for Study on Connective Tissue Disorders. She was a secretary of IDVL in 2004 and president of IDVL in 2009. And her special interest lies in clinical dermatology, dermatopathology, HIV, and aesthetic cutaneous surgery. So with this, I welcome Dr. Bela Shah to this meeting. Welcome, ma'am.
Thank you.
Now, coming to panelists for the day, now we have esteemed panelists for today's meeting consisting of Dr. Sushil Telyani, who is from Mumbai, Dr. Aruni Namdar from Bijapur, Dr. Asit Mittal from Udaipur, and Dr. Anil Ganju from Delhi. So I take this opportunity to welcome all the panel members, starting with Dr. Sushil Telyani.
I'll request you to not read all this.
Sir, just few words, sir. So he is a consultant dermatologist practicing in Mumbai, and he has more than 35 years of experience in clinical dermatology. He is attached to Hinduja Healthcare and Hinduja Hospital, Asian Heart Institute. He's a reviewer of multiple journals and contributed to multiple chapters on various textbooks of dermatology. Has experience in laser in more than 15 years, and he is advisory member of Nail Society of India. So with this, I welcome Dr. Sushil Telyani to this meeting. Welcome, sir. The next panelist is Dr. Namdar, who is a professor and head of department, Shri B.M. Medical College and Hospital Research Center, Bijapur. Has been awarded Best Researcher Award in Clinical Research in 2013 and 14. He was a section editor of International Journal of Trichology. He's a editor board member of American Journal of Dermatology in 2013. He's an honorary member of European Academy of Dermatology and Venerology. He's a visiting professor for pediatric dermatology at University of Chicago, and he has authored a textbook of pediatric dermatology and atlas of pigmentary disorders. So with this, I welcome Dr. Aruni Namdar to this meeting. Welcome, sir. The next panelist is Dr. Asit Mittal. He's a head of.
I would request you to just be pretty brief, and this. I mean, you exhibited this is fine. Why are you reading it?
Just 2-3 words, sir. No, not more than. Sir, he's a head of department and senior professor, RNT Medical College, Udaipur. His special area of interest is pruritus, vasculitis, and advanced cutaneous drug reaction. Has multiple achievements to his name like IIDVL Best Teacher Award and Professor Ratan Singh Award. He's a coordinator of SIG psoriasis and honorary membership of Dowling Club of British Academy of Dermatology. With this, I welcome Dr. Asit Mittal. So welcome, sir. And finally, the last panel member of today's meeting is Dr. Anil Ganju. He is a senior consultant dermatologist and laser surgeon practicing in Delhi. He is a recipient of prestigious Dr. Sardari Lal Memorial Lifetime Achievement Award, awarded by IIDVL, and then ET Aspiring Dermatologist of the Year in 2019. He has also has to his name the IAS Dermatologist of the Year award in 2018, and then he has received President's Appreciation from IDVL award in 2017. He is head of Department of Dermatology in several prestigious Delhi institutions. He's president of SARC AAD and past vice president of IDVL National and past president of IDVL DSD. He is a scientific chair on aesthetics dermatology and has authored multiple chapters in several textbooks of dermatology, cosmetology, and lasers. And he is also reviewer of ACSI Journal of Derma of Journal. So with this, I welcome Dr. Anil Ganju. Sir, welcome, sir. So with this, I now will hand over the session to Dr. Our moderator for today's meeting is Dr. Abhishek Day. Sir, over to you.
Thank you, Dr. Gaurav, and Belasha ma'am already with us. So, madam, can you just start your presentation?
Sure. So you're able to see my screen, no?
Yes, madam.
So shall I start?
Please, madam.
Okay. So I'll be talking about the real world experience of bilastine usage in chronic spontaneous urticaria. Usually at meetings, we always discuss that this drug doesn't work as like pre-existing drugs like levocetirizine, fexofenadine, disloratadine, or for that matter, even loratadine. So what is really happening in the real world situation? So I'll take you through a study which was performed on a sizable population in India. So traditionally what we are using is non-sedating drugs as first-line management of chronic spontaneous urticaria as per all the guidelines, including our Indian guidelines. And still a few patients of chronic spontaneous urticaria, they do not have adequate response in spite of giving them the standard dosage. And many of them fail even on updosing. So it's very common practice in India to switch from one antihistamine to other. And that is also a Japanese guideline. And our own experience, people are using and switching over antihistamines as per their experience. However, there is no evidence supporting switch from one antihistamine to another antihistamine in patients who suffer from refractory chronic spontaneous urticaria. So what is bilastine? It's a novel drug already in the market for more than 1 year, and it is non-sedating drug with a proven efficacy and safety in management of urticaria. However, there is no Indian evidence for this drug, and again, there is no evidence for which shows the efficacy of bilastine, wherein this drug was used in patients who were already having inadequate response to the second-line conventional antihistaminic drugs. So we conducted a retrospective real-world survey with dermatologists across India so as to see the response of bilastine in chronic spontaneous urticaria patients in whom bilastine was added when they had inadequate response with cetirizine, levocetirizine, fexofenadine, and loratadine. So it was a retrospective multi-center observational cohort analysis wherein 140 doctors participated, and a pre-validated questionnaire was used to conduct this analysis. Urticaria control test scoring system as well as visual analog scale were included as part of assessment of efficacy and safety of this particular drug. And data of 898 patients were analyzed. So here you can see the total number of patients who were analyzed were 898. And out of these 898 patients, the total number of patients who had uncontrolled urticaria were 518. And male preponderance was seen, 56% were males and 44% were females. And the mean age of the patients was 35 years. And mean duration of the disease was 7 months. And the patients who were included in this analysis were given treatment with bilastine 20 milligram at the standard dose, that is once in a day for 4 weeks. At baseline, urticaria control test was performed as well as visual analog scale was calculations were put in place, as well as the same measurements were applied at the end of 4 weeks. The patients who responded, that means who achieved urticaria control test measurement more than 12 or equal to 12, were classified as responders, and below 12 were classified as non-responders. So this is the standard urticaria control test, which includes 4 questions, and it is very easy to perform while we are doing some study. And visual analog score includes whether the patients develop sleepiness or are they happy, what was the degree of sleepiness, and whether they think that the drug was effective or not. So these are 4 parameters which were evaluated for urticaria control test, like how much they had suffered from their physical symptoms, what was your quality of life affected by urticaria in last 4 weeks, and how often was the treatment of urticaria was not enough to control urticaria symptoms, and overall how well they had urticaria control for the last 4 weeks. So the patients which were analyzed, most of them were on levocetirizine. 44% patients were on levocetirizine, 11% were taking cetirizine, 13% patients were taking hydroxyzine, 4% patients were taking disloratadine, 2% were taking loratadine. Fexofenadine group was 24%. 1% patient was on CPM and oral steroid, and the associated conditions which was reported in this patient, the foremost being diabetes, hypothyroidism, hypertension, atopic dermatitis, fungal infection, angioedema, scabies, seborrheic dermatitis, and even some other allergies. Here we can see at baseline the degree of sleepiness, which was 3.9%, it came down to 3.5%, and at week 4, that visual analog score, that means the patient who were put on bilastine, degree of sleepiness did reduce, whereas satisfaction with the drug improved by 1%. You can see it was 8.6% at the end of 28 days. An urticaria control test showed improvement in all parameters, like improvement in their symptoms, improvement in the quality of life, treatment satisfaction, as well as control of urticaria at the end of 28 weeks after putting these patients on bilastine. So after 28 days of the therapy, 69% patients were classified as responders as they achieved the urticaria control test, which was more than 12 or equal to 12, whereas 31 patients had still urticaria control test which was less than 12. So coming to the results, a total of 39 patients complained of adverse events, the sedation being the most common, that was seen in 25 patients, fatigue in 7 patients, dizziness in 4 patients, and headache in 3 patients. All the adverse events were mild in nature, and none of the patients discontinued the treatment or bilastine was not withdrawn. So we can say that overall bilastine was very well tolerated by everybody in this group. Now coming to the sub-analysis of this study, bilastine versus patients who were refractory to levocetirizine. As you could see in the chart, 45% of the patients were taking levocetirizine. For few clinical studies have reported that there is comparable efficacy and safety of bilastine and levocetirizine. However, there is no data regarding switchover therapy, which I am going to talk about. Hence, to get the more insight into the efficacy of bilastine, switchover therapy in patients who were refractory to levocetirizine, further sub-analysis was also performed. Here you can see the number of patients who were analyzed and who were refractory to levocetirizine were 230. Again, male preponderance was observed. 58% were males, whereas 41% were females in this group. And the mean age of the patients was 38 years and mean disease duration was 7 months. Again, the treatment provided was 20 milligram because this is a sub-analysis which I talked about previously. And of course, what we utilized as assessment tools was a Urticaria control test as well as visual analog score. Of course, the patients were again evaluated at the end of 4 weeks, employing the same tools, that's Urticaria control test as well as visual analog score, and were classified as responders and non-responders as per their Urticaria control test results. Here you can see that there was significant improvement in each parameter of Urticaria control test, as well as there was considerable improvement in visual analog score. That means the patients were satisfied with the therapy, as well as there was reduction in degree of sleepiness, evaluating and confirming that there was difference in visual analog scale, as well as you can see here in the graph, all parameters of Urticaria control activity improved. Suffering from the symptoms, quality of life, as well as Urticaria under control. And if you can see, the cumulative Urticaria control test improvised from 9 at baseline to 13.5%. So coming to the final sub-analysis of this comparison between bilastine and levocetirizine, 73.4% patients were classified as responders, and 26% patients still were non-responders even to in this group, which was a large chunk of patients among all the 4 drugs. A total of 19 patients developed adverse events. All adverse events were very mild, as I discussed previously, and bilastine was found to be well tolerated by all of them. To conclude, I would like to say that this is the first study probably for real-world experience of bilastine in the management of refractory urticaria in Indian patients. The drugs which are conventionally used, from there, the patients were switched over to bilastine. And there is a study by Weller and Inouye which also concluded that bilastine is effective antihistamine in relieving the symptoms of difficult to treat chronic spontaneous urticaria patients who were refractory to other H1 antihistamines. In conclusion, this study shows that patients who had inadequate response with the conventional second generation antihistamines at the licensed dose, when they were switched over to bilastine at the standard dose, does result in not only relieving the symptoms of chronic spontaneous urticaria, but it also resulted in improvement of quality of life of these patients. Thank you.
Thank you, madam. That is really a good study. I mean, so many participants and so many doctors have participated in your study. That's very nice to know. I think this kind of data used to be missing from India, but thanks to researcher like you, we are having much more better quality data now from India. We need, because all of the time we talk about the experiences of our people which are different, but frankly speaking, there are not much publication or researches from our side. That's why we cannot actually establish that in the world. I had done a similar sort of study, so I like to share my screen if it's okay. Can you see my screen now?
Yes.
Okay, ma'am. Now this is similar sort of, but little different. This is, I was a single center. I mean, I was the only investigator in this study, and it's done over a period of time. And patient I followed up for 6 months, so little longer period of data. And I have taken only those patients who had at least 2 times elevation of normal antihistaminic, second generation antihistaminic, and there's all these refractory patients I have taken into account, and slowly how they responded. Some of them responded, some of them not. So that I have charted over here. So I'll like to talk about. We know all what is urticaria. Urticaria comes sometimes with or either in angioedema. And the problem statement really we have when we tackle with chronic urticaria. And chronic urticaria is usually defined as having daily or nearly daily episodes of hives for more than 6 weeks. Now, we know the IACI guidelines, the central part of the pathogen, Center for Management of Urticaria, chronic urticaria, according to the IACI guideline, and most of the other guidelines is basically second generation antihistamine and we can usually updose to up to fourfold. That's the standard recommendation all over world, including the Indian guidelines also. If not under control, then your key guideline guidelines suggest that the third line of treatment is omalizumab. And if we somehow fail with omalizumab or omalizumab cannot be given for some other causes, then we can also try cyclosporine on those patients. So this is the standard guidelines for that. And though we tend to agree with the guidelines at times, for Indian perspective, it's not that easy that we can always stick to the guidelines, and that's why we have varied kind of experience and exposure. And India is a very difficult country because of the cost factor, different racial factors, different cultural factor, and social taboo associated with treatment. So I would like to discuss about all those things when we come to the panel discussion. However, we know the second generation antihistaminic can be divided now as a minimally sedative and non-sedative. If I can further elaborate, mostly it's understandable that bilastine and the fexofenadine are put together as a non-sedative group. All other second generation antihistamines are clubbed together as a minimally sedative drugs. However, it has been shown that only 78% of our patients achieve a good outcome in spite of updosing. So even with the updosing, you may not achieve full response to many of our patients, about 1/4 of our patients. So that could be challenging at times. So there are basically two major factors what creates a problem while you treat CSU. One is, of course, the clinical efficacy, and the patient should have a good compliance. That's why we need a rapid onset and long duration of action with this antihistaminic. And also there are things like unwanted side effect, especially when you updose. Many of these minimally sedative antihistaminic become sedative, and that can be a problem for many of the patients who needs to go out with their walks and daily activities. So these are the two important aspects where we need to be careful while choosing our molecule in the treatment of CSU. And I think this is what bilastine offered to us, especially about 1.5 years back when I started writing bilastine and collecting my data. This is primarily field of interest because bilastine is widely regarded as non-sedative, and second, it has a rapid onset and a long duration of action. These two was interesting for me, and so I tried bilastine. It has been recommended dose is 20 milligram we know, and it's been recommended more than 12 years now. In European Union, this has been tried in 6 years and above also. So in future, possibly bilastine can be given for younger children also. So bilastine has been assessed in multiple clinical trials. So this is, unlike some of the molecule which has recently come to India, bilastine actually has a good clinical trial data available, and it is recently introduced to India after the approval of DCGI. It has already been used quite widely in Europe. However, there are restricted availability in American continent, so that could be a challenge of data for bilastine. There is a paucity of evidence, however, about the long-term efficacy safety of bilastine in Indian patients. You know that there is a pharmacogenetics associated. We do not know how much data is there and how much the safety or the efficacy for Indian population. So we undertook the study to, it's kind of retrospective analysis of the features of the long-term efficacy and tolerability of bilastine for the CSU patient of India. So it's, I have taken this challenge when initially the bilastine was introduced, and the publication was ready and sent to Indian Journal of Dermatology, and it's accepted for publication, provisionally accepted for publication. So we expect the data to be published in another 3 to 4 months. This retrospective chart analysis was conducted in Russia in Calcutta. Following a patient were included in the analysis, the patient with unsatisfactory response as per US 7 score to previous antihistamine therapies, either on a double dose of previous antihistamine or on two antihistamine combined at a licensed drug. So it's both kind of patient I have taken. And also the patient who switched over to bilastine, all those patients switched over to bilastine 40 milligram per day and continues for bilastine for 6 months in varying doses, and bilastine depending on the response. So I have taken those patients who has been shifted to bilastine and taken the drugs for 6 months, and that's why we have a kind of longitudinal data available with us. Assessment were done at regular intervals, that's monthly basis with US7 score. And I have also done the quality of life assessment at the beginning and at the end. According to the clinical response, the bilastine dose was either increased gradually to 80 milligram per day, and if the response is achieved, then decreased to 20 milligram per day. So it was kind of we stuck to the guidelines, how they suggest us to increase the dose or decrease the dose according to the response pattern. And we know that US7 score and quality of life assessment, this is pretty commonly used. So we have used this generalized tool. Thankfully, because we have this Urticaria clinic going on, so we had this data and we have the pool of patients already. So it was easy for us to trace back those data. Now, this is the patient. We had about 49 patients enrolled before we sent the article for publication. Now we have, I guess, about 72 patients or staff. So we maybe in future will publish more data. At least 13 of them had a patient was in double dose or more, and 36, that is 73% had more than one drug. So you can see from here also that combination therapy is more used in real life than actually the updosing. Some of the patients has comorbidities associated. Now we know that urticaria patients can have comorbidities. They have hypothyroidism, 9 of them, had diabetes in 3 of them, and 1 patient had hypertension. Now, another aspect of comorbidities, because bilastine is another interesting drug because it doesn't have too much of drug interaction, so it can be an interesting drug in all those patients who are on polypharmacy. 84% of the patients were in moderate to severe urticaria at baseline. That is, mean US7 score we found about 20, and complete response and oil control response was observed in 42% patient at week 4, and 71% at week 8, and 91% in about week 6, and about 100% in 24. So when the patient is in 24 weeks continuous treatment, we can find most of our patients, rather all of our patients, gave a complete response. However, some of them, other drug has to be added. That I'll be discussing later. At the end of 24 weeks, 51% of the patients achieved complete response, that is US7 score 0, while 49% of our patients were labeled as a well-controlled urticaria, where US7 score is less than 6. And the mean US7 score also showed a decline over the 24 weeks. At 24 weeks, the mean US7 score was 1.35, which was statistically significant as compared to baseline. If you remember, the baseline mean US7 score was about 20. So it was quite a drastic change over 6 months while we keep the patient under bilastine. So this is the response. You can see over 24 weeks how more and more patients got into the zone of full treatment response, or at least well-controlled urticaria. So that can be shown in the graph. And if you see how this mean US7 score and the quality of life changes happened over the 24 weeks, these graphs are showing those. 9 patients required updosing of bilastine to 60 milligram, and 6 of them required up to 18 milligram at week 8 and 12. So some of them required, some of them not controlled with the 40 milligram bilastine and had to be updosed. In addition, dose reduction trend also seen in patients from 8 weeks onwards. So some of the patients, when we are well controlled, we also decreased, while 11 patients at week, and 27 patients at week 12, and 35 patients at week 16, and 40 patients at week 20 were shifted to bilastine 20 milligram per day. So patients who have achieved good response at less than US7 score 6 or complete response, all those patients have been shifted to lower dose of bilastine also. At the end of week 24, 43 patients were in bilastine 20 milligram per day. So they are actually kind of controlled over minimal amount of bilastine, the other pharmacological dose of bilastine, and 6 patients were on bilastine 40 milligram per day. However, these are the 6 patients which is a better control urticaria on bilastine 40 milligram per day. This patient hasn't shown a complete good response with bilastine 40 milligrams or elevated dose of bilastine 60 and 80 milligram. These patients had to be added with cyclosporine, or one patient also added with omalizumab because patient wanted more symptom-free remission. while we have added cyclosporine and omalizumab, we have reduced the dose of bilastine to 40 milligram per day. Based on the quality of, based on the DLQ, the quality of life was moderately severely affected 88% patients, 88% of the patients in baseline. At the end of 24 weeks, CSU has no effect on 57% of the respondent, where 43% of the patient has a small effect on their quality of life with the CSU. The mean score of DLQ also reduced from 1.6 to 1.63 at 24 weeks from the 8.39 at baseline. So there's a good reduction and it's statistically significant also. About the safety, about 5 patients complained of sedation, but it was mild in nature and did not require the discontinuation of the treatment. Most of the patients are actually elevated dose of bilastine, more than 40 milligram per day. Overall, bilastine was well tolerated in all of our patients. The present study is we believe that is the first real world study in India, before I saw Madam's data, assessing the long-term effect on switching over to bilastine in CSU refractory to other antihistamine. Updosing to bilastine 40 milligram appears to be effective strategy in patients with refractory urticaria. After achieving initial control, patients can be maintained with bilastine 20 milligram per day for long term, as seen in the study. Bilastine was associated with significant improvement in quality of life and as well as well tolerated over a 24-hour period. And only 5 patients showed some side effect, including mild sedations or to high dose of bilastine. In conclusion, this study showed that in patients who had inadequate response with commonly used second generation antihistamine at double dose or combined dose, switching over to bilastine at 40 milligram per day resulted not only in relieving the symptoms of CSU, but also improved quality of life in these patients. Thank you.
So thank you, sir. Thank you, Dr. Bilasha and Dr. Abhishek De for presenting your experience of bilastine in management of refractory patients with urticaria. Now I would request again to Dr. Abhishek De to moderate the panel discussion, which will be happening on the management of urticaria in patients during this COVID-19 pandemic. So I request all the panel members and the moderator to, sir, over to you.
Thank you, Dr. Gaurav. So this will be another interesting segment, and anybody can share their views or the questions, whatever they have. So I have a base questions, but however, it should be more free flowing. So anybody can chip in with their answers, or anybody can suggest. All the panelists are very extremely well known and very highly academic people, so they can all contribute to ours. That will be very interesting, I believe. So let me share my slides first.
Can I ask a question about your talk?
Please, sir.
So you normally the rule is that when we updose from 40 we go to 80. You went from 40 to 60, then 60 to 80.
Yes, sir.
Any reason behind that? And secondly, when all of them responded in the DLQI, you said 43% had some negative effect on the quality of life at the end of 24 weeks. What was this reason for the effect on the quality of life in 43%?
I do not know, sir. I mean, quality of life, it cannot be always directly transmitted into the efficacy. We saw some minor effect on that. Maybe the patient was not happy with taking 4 tablets a day. Maybe the patient was little sedated. Some patient also had some symptoms. It's not that all of them are completely symptom free. They had under control, that US7 score less than 6, but that doesn't mean there's a complete control. So there can be multiple factors associated with that. Maybe the bilastine, buying 4 tablets is also costly for some, or 2 tablets per day is costly for them. Maybe they don't want to come to the clinic every day, every month. So there can be multiple factors. Everybody wants to get completely free of symptoms. That was not the case, I guess.
Thank you.
Yeah, Dr. Abhishek.
Yes, sir.
Dr. Ganju here. Yeah, I'm happy that you switched over to 40 milligrams straight, because the The standard recommended dose is 20 milligrams a day. But I practically see that at least 40 milligrams is needed even to start the therapy. I would want the experience of other panelists. I feel that you have to start with 20 milligrams a day relief from symptoms. I don't believe 20 milligrams is the standard dose.
I can rationale my study design that I can do because I have taken refractory urticaria and I define refractory urticaria when the patient was non-responder or less responder to at least 2 times elevation of antihistaminic. So since I'm shifting to 2 times antihistaminic, I needed to start another antihistaminic which is at least double that pharmacological dose. So this is the rationale behind why I have started on 40 milligram, but I'm pretty sure everybody.
But you see, the point is that the recommended dose should be 20 BD. You know, because of it being recommended as 20 OD, many of the patients do not respond to that dose. I feel practically so. Many of the clinicians might be thinking that it's probably not an effective, efficacious drug. If they are told that they have to start with 20 milligrams BD, probably they'll have a better experience with the molecule.
Dr. Ganju, may I chip in here? Yeah.
Yes.
Yeah, I think I would differ actually. I am getting reasonably good response with 20 milligram daily also. I mean, like with the other antihistamines, there are situations where you have to updose, but you can't say that you start with 40, in my opinion. Second thing is, until unless you have a head-to-head comparison between 20 milligram daily and 40 milligram daily, it's very difficult for you to generalize or to recommend something to your patients, to your colleagues. Till then, it should be you start with the standard usual dose, and then, as with other antihistamine, there are situations where you have to updose maybe 2 times, maybe 3 times. But what is very clear is that even with updosing, there are no safety issues, even with Belastia. So I think I would stick to 20 milligram daily, going to 40 milligram if situations demand.
Sir, can I chip in with a point, sir? I think there's a little bit difference how the data is generated and how we see patient in real life. Data is more of restrictive, but a patient with chronic spontaneous urticaria is first time presenting for a doctors and they are giving us one time 20 milligram and this data size about 40% patient respond to that single tablets in the standard dose. When you updose to 2 tablets, the data service is about 60% give response. So there is a good jump from 1 tablet to 2 tablets. However, when we see the patient, most of the patient, I guess they are already on some kind of treatment. They are taking OTC drugs or they have already shown the GP. They have already 1 tablet. So we are seeing a selective group of patient. And as per Dr. Ganju said, on those group may not be the 1 tablet per day give adequate response. That could be one challenge.
And can I just make one comment before
Yes,
you
sir.
start? So I would congratulate Dr. Belasha for having got 898 patients who were on the licensed dose and they did not try the updosing.
Yes.
That's a big figure that you had of patients who just tried the standard licensed dose of the previous antihistamine and they did not try a higher dose.
So I don't really updose my patients as per the guidelines, as frequently we talk about the guidelines. And this was data collected across India from
country,
140 dermatologists. It was not that 189 patients were enrolled by only my center. We contributed 40 patients, but then who had inadequate response to the standard therapy and they were not on any updosing of the therapy, and we waited for 8 weeks. When they failed to respond or they had inadequate response, they were not happy with the therapy, then we have given only Balacin 20 milligram and that too at a standard dose.
So
they already had inadequate response with the previous standard therapy.
Correct. So because of which we got a lot of useful information on a large patient base.
Yeah, that's what. And we could evaluate out of that 512 patients.
Very
Okay.
interesting.
My opinion regarding the dosage schedule of Bilastine, if they are treatment naive patients, which accounts very less number in practice actually, or even in tertiary care center, I would go with 20 milligram only. Unless they come with so many papers, already I have done this, that, then probably I would go with the 20 milligram BD for a few days till the patient feel definitely no urticaria lesions for at least 3 days. And then you can reduce it also. Anyway, what matters is it is a receptor blockade and reduction in the symptoms. That's all. So it's nothing like antibiotics where you have to give this much for an MIC like. So all these anti-allergic, anti-inflammatory dosage schedule is variable, and our goal should be the achievement of clinical clearance first. The patient satisfaction that, okay, I'm not getting the symptoms which are associated with my disease, probably. Okay.
Okay, that's so nice. Already a lot of things we can learn, and we can learn that from our esteemed panelists that bilastine fasting even works even in the standard pharmacological doses to many of our patients. And where the patient is a little bit more complicated, the patient has already tried a lot of drugs and coming to us, then we can safely updose. So this part of the message is very clear from our panelists. We need to talk about COVID-19 as per the panel discussion topic. And before I go into urticaria and COVID-19 and bilastine, all those complex things, I want to know a simple question I answer from you. When the COVID-19 will go, sir? When it will improve?
No answer to it.
$1 million question.
Very
We are
simple question,
midst
sir.
of it as of now.
Let's talk science and not start guessing.
Yes, that's what.
So
Yeah.
So I guess
The vaccine does
for
some magic.
first, I guess for the time being, we need to talk about COVID-19 and different disease treatment for few more months or years, if not. So let's talk about urticaria and some problem with my stuff. Let me fix it. Okay. I'll start that. This is a lot of people have been saying. I've been watching a lot of webinars that they have feel the number of patients of urticaria has increased during the pandemic. Anyone has anything of sort noted, like number of patients of urticaria has increased?
Not really. My experience, not really.
I think urticarial rashes can happen in patients of COVID.
Yeah.
That is known, and we have seen that. But the disease prevalence having increased because of COVID, I don't think so.
Urticaria otherwise also is so common. It's very difficult to feel whether they've increased or not. I don't think so. There's no registry as such with us.
I can only say
we
that
do analyze our patients every day. Each disease is analyzed, but I don't find any increase in incidence of urticaria in this pandemic, because we already see almost 400 patients every day. So I don't think there is any increase in incidence of urticaria as far as our center is concerned.
Same here. I mean, in our OPD load is almost the same what it was pre-COVID these days. In hospital, I'm talking. So the incidence of urticaria seems to be doesn't seem to go up quite high. I agree.
Sujil sir, you
I totally agree, except for the fact that some of my patients have had urticaria post-recovery from COVID, and these are people who need a higher dose of antihistamines. They are a little more resistant to treatment. I find that it's a little more challenging in those cases.
So that is one thing very important, that like any other viral diseases, also urticaria can be symptoms, and sometimes the presenting symptoms of COVID infection also. But have any of you have seen any patient who has come to you as an urticaria patient and then later it's been found to be COVID-1?
Yeah, I had a very distinct experience. I would go with the background. Like urticaria can be one of the earliest manifestation, number one. But every urticaria cannot be the manifestation. How do you recognize them is an important thing. Usually associated with some upper respiratory tract infection or fever will be there. And if you do, one of the easiest thing to recognize would be do a CBC and absolute lymphocyte count, which will be reduced. And with that in mind, if you can do, of course, if possible is there, X-ray or the HRCT is the best thing. I have, in fact, the patient was a doctor actually, and I had to get done because the patient was working in one of these government hospitals where a lot of patients used to come and meet for the consultation and all. And then I just told, as absolute lymphocyte count is less, let's take an X-ray actually. And then somehow X-ray was normal, but somehow I was very much worried about that lymphocyte count with fever. And then I told HRCT. And there was very classical picture. What I would like to highlight is if urticaria is associated with fever, and please get done CBC, absolute lymphocyte count less. And if you are very much sure that is a high risk patient, for example, if the patient was like healthcare worker, and then probably better to go for HRCT if facilities are available. Otherwise, I think that was my experience with urticaria. Otherwise, other routine RTA cases keep coming, but I will only look at these symptoms and definitely do an CBC. Even it is similar with herpes zoster. If they come, I will get done the CBC and see the absolute lymphocyte count.
Two of my patients of varicella turned out to be COVID.
Yeah.
They were not varicella, you know. I had started them on anti-varicella and then they turned out to be COVID positive.
I would share two of my patients. One was urticaria, a child with, as Dr. Inamdar was saying, was having fever. Urticaria, and what he said, I would say that absolute lymphocyte count plus neutrophil lymphocyte ratio. That also is important. Neutrophils are more than, or neutrophil lymphocyte ratio is in favor of neutrophils. Then probably that's another clue. So this child was having URI kind of picture and a fever and urticaria. Urticaria was no different from the routine urticaria that we see.
Yeah.
But he was picked because of this. And one varicella, Dr. Ganju is saying, I remember having seen a case in March with a young female with very extensive varicella, explosive varicella, and not pleomorphic lesions. She was having only vesicular lesions all over the body. And then we did not suspect naturally at that point of time any COVID or something. She was treated with routine care, what we do. And then I learned about 3 weeks later that the girl succumbed, or 4 weeks later, from one of her relatives. So I wonder whether it was COVID, because the presentation was that. And then if you find the literature, you see that loss of pleomorphism, the monomorphic lesion is one of the factor which points towards COVID.
So these are very interesting learning curves, and so we know that we always knew that urticaria-like lesion can be a manifestation of COVID-19. We also, there are literature suggesting that Bullous disease had been also a part of the COVID cutaneous manifestation. We learned an interesting thing that this could actually mimic like chicken pox or varicella infection. So that could be really challenging because we both see urticaria or the varicella in our practice quite routinely. So do you suggest that in similar situation, we should go for COVID-19 test for every patient of ours?
Not at all.
I think Dr. Inamdar very rightly said that if you have associated symptoms of URI and anything suggestive fever, anything suggestive or a high risk, for example, as Dr. Inamdar mentioned, or has had contact with a patient, then I think we should.
And CBC would help you.
Correct. So lymphopenia is very important.
So basically, we in routine tests also a lot of us suggest that CBC and CRP can be done in patients of urticaria because this gives us additional clue about some infective focus in the body. So we should always do. Another thing we knew from the discussion that, urticaria patients who actually presented COVID or post-COVID, as Dr. Sushil sir has told, that this patient can be more refractory to treatment than the standard urticaria patient. That's one challenges can be. And another challenge we learned that, varicella patients, COVID can be a varicella mimicker also. That could be a really big challenge because we hardly suspect those patients to be COVID-1. So these are the things we need to keep in mind because COVID is going to stay as per our panelists for a few more months or if not years. I'm always having it. So this is, this is the part of the diagnostic challenges of COVID-19. But do you think that our management algorithm has changed? Sushil sir, how do you manage the patient which used to be before pre-COVID era and you are managing your urticaria patients differently now?
I'll definitely use the same standard treatment. The challenge will come when patients don't respond to the updose version of antihistamines. And when in India, they cannot afford omalizumab, and if I had to think of some immunosuppressive drug to be added, that's when I'll take the background of the patient more carefully and be sure the patient does not have any upper respiratory symptoms and fever. Be sure patient is not a healthcare provider and patient is not a high risk group for COVID infection. In case the patient is, by for example, in Mumbai or Delhi, the entire population will be at risk. So then you have to monitor them closely, and you can still give them under close monitoring the immunosuppressive drugs. That's where I'll be careful.
I think I'll make a comment here. This group who has not responded to antihistamines, and we have to go to one of the immunosuppressants, which is very common in urticaria. I feel that they become high risk patients, like patients with comorbidities. I am skeptical doing it, but I have to do it. And then I tell them that you have to be extra careful. You have to be very, vigilant. You have to be very, careful with mask, hand hygiene, respiratory hygiene, and respiratory, care, etc. So, but I have been giving, as I have been earlier, the immunosuppressant.
And if possible, I tell them to be in home quarantine, if possible.
That is interesting. Arun sir, I want to know few words from you, like a take-home message for our delegates. So, do you believe that antihistamine 4-dose elevated, up to 4-dose elevated, like we standard do, or even combination, whatever the people are doing, is completely safe even in this COVID era?
Yeah, I would agree with Dr. Bela Shah and a few of the panelists there, that there is not necessary to increase or updose any antihistaminics. If it acts, definitely it has to act. On the contrary, I would add one more antihistaminic of a different group rather, and invariably I get the good results. I don't think it is really necessary to take the updosing. What happens, I don't know. It may be very much true in the places of ache like Bombay and other things, where patients should be little intelligent enough and they may hear, okay, take 4 tablets. If I tell in place like mine, like a district place, if I tell 4 tablets, then they will take only 1 or half of that, 2 tablets. Even including me, if I'm asked, if I'm not a doctor, if I ask to take 4, ज़्यादा होगा, थोड़ा 2 लेके देखेंगे क्या होता है. So that mentality is very much there. Unless the tablet itself comes with a 40 milligram. Then if it is a scored one, then it is a nice thing. Here the number also matters for the patient psychology. Okay, and you don't have, when we see about 100 patients per day or about 400 in civil hospitals like Bela Shah's or Ashit Mittal or wherever I was also working earlier in a civil hospital, 350 patients or 400, you don't have time to convince that the science says that, okay, updosing 4 times, then you will be better. And invariably, some headedness will be there. I'm sure. Only thing, I don't know how they are galvanizing that or pushing that doubling the dose or 4-time dose. I really do not understand. And if it is a really receptor matters, if it is going to be block those receptors, definitely there will be an action.
Sir, actually,
I don't believe give the loading dose unless the pharmacokinetics suggests that you need most of the second generation antihistamine within 2 hours they work. Less than that also. That is the difference between first generation and second generation, and the metabolism also differs between them. So you can use it in people with SIP, like especially desflurotidine, for example, or the whatever development has happened because the lesser cardiotoxicity. In fact, the first antihistaminic, the first generation was 1946. Only after almost 45 years, 1980, second generation started. So that means, as there is not much difference between the actions of whatever generation of antihistamine we are developing, except that, okay, we need to reduce the sedation, is the crux of this development of all these antihistamine. When Bilastine, with its pharmacokinetics known to all of us now by this time, less sedation or hardly any sedation, I can tell.
I'll just tell you that human being the same everywhere. In Mumbai also, patients are comfortable taking 5 milligrams levocetirizine and not 180 milligrams of fexofenadine because that is 180. they go by 180 being stronger than 5 milligrams.
Strong, jada strong hai sir. 1000 milligram if you tell, like for example, herpes zoster, we have to give 1000 milligram. Oh, बहुत ज़्यादा है सर, उसको आधा किया मैं बोल देता हूँ.
Oh, Dr. Abhishek, may I put in one word here?
Yeah, please, sir. Please,
I
sir.
mean, we need to understand that antihistamines, they are not receptor antagonists.
Yes, sir.
Mhm.
Yes, sir.
They are reverse
Yes,
agonists.
inverse agonist.
I mean,
Universal.
and they are part of G protein coupled receptors.
Yes, sir.
So it's not like blocking the receptor sites.
Mm.
So I think pharmacologically, it makes sense to raise the dose of a single antihistamine rather than using two antihistamines.
Yes,
Because you're not actually doing, you're not blocking, say it's a receptor, you block there, it's not something like that. They are constitutively expressed on
Yes.
the cells where they are. And being the reverse agonist, you are just suppressing that expression. So I think,
So
in
there
my
are,
opinion,
I,
raising the dose makes a sense rather than adding another antihistamine.
so that's the logics come from basically scientific pharmacoanalysis, say that these are the inverse agonists, and so a 4-time elevation is when we find it safe is actually all the data suggests that this can be used. But when you use two different inhibitors, inverse agonists, they can be working competitively. So it may not be 1 + 1 = 2. That could be a big challenge for this. However, I understand SAT's point of view. India is a very diverse country, and a lot of our patients has different kind of taboos. So we need to keep address while we will in real life we have to treat our patient, and that's why we are gathered to gain the real life experiences. Another thing, sir, fast generation antihistamine has another problem. This works also on the other receptors. That is not only about the sedation part of it. It's also that there's an anticholinergic side effects. All those things we do not want in our patient. That's why you have shifted from first generation to second generation, because these are more selective antihistaminic rather than we are not blocking all those molecules or all those receptors, which is not relevant to our practice. So that is why talking about we now understand at least all kind of antihistaminic and even the up-dose and even the combinations, whatever our standard practice, possibly do not require to change, because this antihistamine is very, very safe even during this COVID pandemic era. That's what the message I want our delegates to get from our panelists, and that's what exactly they delivered. Talking about the, I will come later to the omalizumab, though the omalizumab is considered the third line of treatment, but I need to talk about the cyclosporine, because cyclosporine is possibly only to-go drug for many of our patients. A lot of our patients cannot afford omalizumab. So, Sushil sir, just let us know, are you using cyclosporine right now also? And if you are using, what are the restrictions you are following?
I told you a few restrictions, but when I write it, I explain to the patient that on label it is an immunosuppressive drug, but there are studies to show that it may have some antiviral properties because it slows down progression of viral replication in the host cells. Secondly, at a later stage, it may also have a good role to play against cytokine storm. So it may not be bad. It may be a useful molecule if you take due precautions. But if they develop any symptoms of COVID, even then there's a mild symptoms, you can still continue, but anything more than mild symptoms, you have to withdraw it for the time being and manage it along with the intensivist or with a infectious disease specialist. But even up to the mild COVID symptoms, under close monitoring, cyclosporine can be given, but patients should be monitored closely.
Sir, Ashit sir, what dose you have been writing cyclosporine? Have you started with lower dose of cyclosporine of late now because of the COVID situation?
Yeah. I think in COVID, you need to put your patient as low a dose as possible. So, there is a dissociation in cyclosporine too. It stabilizes, it has an anti-histamine kind of action also against mast cells, besides being an immunosuppressive. And sometimes on a very low dose, that action can be produced. So what I totally agree with what Dr. Sushil has said. And you need to start patient on a very low dose, say 2 milligram to 3 milligram per kilogram body weight. And if you are able to get it under control with that dose, you need not go higher. Usually you use about 4 milligram to 5 milligram per kg, but you can get the desired result even with lower doses. So in my take here in COVID time is that we are using cyclosporine, start at a low dose, say 2 to 3 milligram per kilogram. If you are able to maintain at that or get response at that, no need to go higher. And with all the other precautions that Dr. Sushil has already mentioned.
That is perfect. So this is the message from the panelists that cyclosporine still can be used even during the COVID era. The lowest possible dose, which is good enough to control the symptoms, that should be prescribed. We should not go a little beyond that. You don't have to, stick to the prescribed guidelines of 5 milligram per kg or all those guidelines. Whatever the lowest dose is possible to control the symptom, that's good enough. This patient should be little more sensitized about the COVID-19 precaution, because we do not know yet how safe this molecule can be in longer run. However, some data has come from French group. At least there have been publication of about 180 patients on cyclosporine. They have found that the cyclosporine has no bad impact on COVID situation on those patients. So we are having some data, so that's why we can still write cyclosporine. About omalizumab, Bella madam, you use omalizumab, I guess, a lot. So
Yes.
what is your experience of omalizumab? Should we write it? Any other precaution we need to take care about this COVID-19 situation?
So right now I would talk first about cyclosporine, because I have continued my patients who were on cyclosporine, and we are monitoring them closely. So patients who were already on cyclosporine, they are maintained on cyclosporine. We have reduced the dose, and we have not initiated new patients of chronic spontaneous urticaria on cyclosporine. And coming to omalizumab, actually omalizumab was not freely available, and now it is available. We have counseled a few patients, but then cost is a big deterrent here. So I've not used, at least in post-COVID era, in any of my patients, omalizumab. But I think it's a safe drug, and we can use it if there is a need.
So that is the point. Omalizumab is not immunosuppressive. That's the best part of it. So we can use omalizumab safely during this COVID era. So there's no question of stopping the omalizumab. Rather, if we have a choice, then omalizumab possibly preferred drug over cyclosporine. All those patients who are refractory to the antihistamines. Talking about oral steroids, Arun sir, are you writing oral steroid for urticaria or any other disease for now? And if you are writing, what could be the doses for those patients?
No, as far as urticaria is concerned, especially the acute urticaria where the COVID has been ruled out. In fact, of course, COVID also now the treatment is
Steroids.
is one of the so there is no fear of using steroid, number one. Where do I use actually acute urticaria patients for 3 days? Invariably, I use the parenteral, the hydrocortisone hemisuccinate or something else for about 3 days, and then continue with the antihistamine. Otherwise, as such, I don't just use the oral corticosteroid in urticaria.
Any other panelists having reduced dose of oral steroid, anything recommendation has come up for those?
For acute flares, you can always use short course of steroid, even in your patients who are inadequately controlled and who develop flare, even in COVID era. But there is no point in using them for a long time, as suggested by the guidelines. And recently I saw 2 arterial vasculitis patients. Almost last month I saw 2 of them, and biopsy proven. And there you have to use steroids for a long period of time. So it's not that you cannot use steroids. And almost 15 patients of pemphigus, we had new cases during past 3 months. So we have to use steroids. Of course, we have to use steroids. So you have to use steroids, not for not all autoimmune conditions. Also, for that matter, even if there is a need for urticaria patient for short duration of time, of course, you can very well use steroids.
So in need to use steroids, you need to treat our patient as required. However, in case of chronic urticaria, steroid is usually not the recommended treatment. If you have to ever use steroids, it should be very short, like Arun sir has already turned out all those patients where there are angioedema and other symptoms which can be causing a problem to the patient. You can use maximum of 7 days of steroids, and then you have to depend on your antihistamine for more long-term control of the disease. So that's what the panelists has spoken about. Talking about moving out from the COVID situation, Sushil sir, what are the investigation you ask for urticaria patient in general when the patient first time comes to us? Any changes because of the a lot of new things has come in the urticaria pathogenesis over the last couple of years. So have you changed how you investigate those patients?
In fact, I ask for very few investigations, except if I suspect an acute urticaria infection to be a cause, then ask for a few basic investigations. Otherwise, most of the times when I ask for investigations, it does not help me one bit in my management.
So investigation in general is avoided. Still, any investigation you like to do at the first go? Any other panelist?
Counts, and yeah, please, Dr. Mithil.
No, just what you said. Basically, I asked for accounts to have a look at what is ESR and other parameters. Occasionally, I might ask for serum TSH and T4, free T4, because you don't have anything with you to call urticaria an autoimmune urticaria. So you sometimes try to find some indirect answers. Going for thyroid antibodies is quite costly. So usually I ask for TSH. If TSH is raised, then I presume that this is autoimmune urticaria, but that's very indirect. And recently we were doing a study where we were actually, since D-dimers were available now, so we were just wondering that what is the role of D-dimer in urticarias. So we were doing it, but it's a very, it's part of the study, not routine kind of thing. So I also agree with him that no investigation is required, except I do CBC, ESR, and occasionally serum TSH and free T4.
Okay. So that's what, that in general, we should not be doing too much of investigation for our patients in urticaria, especially a patient who doesn't require much difficulty in treatment. However, some of our patients may be suffering from urticaria for a long period of time. If they are female, if they have some associated symptom like arthritis, or certain such situation which shows the patient may have autoimmune disease associated. If you see some kind of clinical picture, then you may do some of the investigation which is necessary, because now at least a portion of our urticaria patients are associated type 2B autoimmunity, which patients needed this like tests like anti-TPO antibody, sometimes anti-nuclear antibody or rheumatoid factors, or all those things can be positive in this group of patients. But these are very small group of our patients. In general, routine investigation should be avoided for those patients of urticaria. Talking about the updosing and downdosing of antihistaminic, Ashit Miller sir, do you follow any particular protocol?
In fact, we discussed it that if a patient is not treatment naive, it's already taken a lot of treatment, urticaria is poorly controlled, then you may start with higher dose. Usually in a treatment naive case, you'd like to stick to standard antihistamine dose. And as Dr. Inamdar was saying, our goal is to achieve disease-free kind of thing. So if patient is okay with standard dose, fine. I wait for about 3-4 days, maybe a week. And if urticaria is not controlled, I updose it. I often go 4 times. I was not good doing it earlier. I was adding another antihistamine, but I'm more comfortable now updosing up to 4 times than changing the antihistamine or adding any antihistamine.
So that is an interesting note that more and more of us have started using updosing as a treatment of refractory urticaria. Bilashar, madam's study is really interesting, so I'll come to you, ma'am. We are not usually recommended to switch antihistamines. We kind of traditionally believe, rather the guidelines, everything suggests that if you change between antihistamine to another antihistamine, there should be no differences as far as the efficacy pattern. So you choose any antihistamine, you updose till 4-fold, because that's how
I don't updose 4-fold. I updose twice, or maximum I'll do 3 times if it is fexofenadine, because levocetirizine does result into a lot of sedation if you updose it 3 times or even twice. So if it is fexofenadine, I do updosing up to 3 times, not beyond it. But for levocetirizine, I do it only once or at the most twice. This loratadine and loratadine I have made twice, but not 4 times. Any of the drugs I have never used 4 times. I do give single drug as per the guidelines. I never add another antihistamine of first generation at bedtime after being part of this guideline. So I don't use 2 antihistamines.
I understand, man. What I'm trying to suggest
yeah, you said why you switched over, right? That
if
was
you
your
switch
question,
over,
no?
Can there be some benefit, at least a portion of our patient? That is very interesting, because this is not widely studied, I guess. I mean, do you think that if one particular antihistamine is not working in the patient, if you switch to another antihistamine, this antihistamine can give you the, it's irrespective of the bilastine. It can be some with other drug also, which can be studied like that. So do you think some of the people give response better to particular antihistamine amongst the second generation antihistamine?
Yeah. It does happen. I have seen most of our patients are happy with levocetirizine, and many of them are happy with this fexofenadine. But there is subset of patients who are most happy with this loratadine. There is a subset of patient who is most happy with this loratadine. Definitely in my patients, I have seen that.
I would agree with you. So actually, because of your study, now we have one more viewpoint that updosing may not always be necessary. Switching from one to the other through this study may also be helpful.
That is very interesting. So this is something interesting because we need to study the pharmacogenomics also. It's some particular patient is not, we always talk about the standard deviations or the mean results, but there can be a subset of the population by the outliers who may get better result with a particular type of antihistaminic. And I think this is something what Bela Shah madam has already studied, need to be studied much more, and we should come up with the pharmacogenomics or some kind of biomarkers to find out which antihistamine can be better for which group of patients.
That's very likely. That should be studied shortly.
Arun sir, please.
Just with due respect to my friend Dr. Asit Mittal sir, within 3 days, would you like to updose? Like, for example, the patient says 3-4 days, the response is not good.
No, as I said,
what I would think is, when I start the treatment, I ask the patient. Sometime what happens, we prescribe for 1 month, and with gap of 15 days, he comes, nothing, still it is there. The first question I ask is, when you were on the drug, was there any urticarial rash? He will say, absolutely no. That means it is working, number one. Sometimes within about 2 weeks or so, patient comes to you and tell, so it has not improved. Then I ask, every day with the dose which I am giving, still you are getting, or once in a while you are getting. If the patient says once in a while, I insist or persist that, okay, you continue with this for another 2 weeks, then come. If it really coming every day with the dose which I am giving you, probably that is the case where you may have to updose, at least for two times or so, or add one more, which many of you disagree with. But really, we are happy that we add something else, patient feels disease free. Is it psychological or placebo effect? All those things is very difficult, or out of our discussion purview, I believe. So I just wanted to know from Dr. Asit.
No. You see, there are situations
within 3 days only.
There are situations. Suppose a patient comes to me with chronic urticaria in very anxious state. So I know that here is the patient whom I need to give some really sedative kind of thing, hydroxyzine or doxepin or whatever. So, I mean, there's no hard and fast rule as such. So you start with your conventional antihistamine, and then you can add one sedative at bedtime also.
Okay, I agree with this point. The whole idea of treating urticaria is there is no hard and fast rule. You have armamentarium, how best you can use to reduce the, improve the quality of life rather.
Absolutely.
Completely cure it.
Absolutely, sir. I completely agree, because for our delegates also, the guidelines are not doctrines. As long as we know the basic evidence, and then we can manipulate that fact into our practice, that gives our best practice. So that's why we required guidelines, and we required real life experiences, especially for the population of India, which is a very diverse population, I guess.
I would agree. In my practice, I wait for a week, but if the patients telephone that they've not slept for 2 days, then I can't wait for 1 week. Then I like to updose a little earlier.
Yes.
That quality of life has to be assessed. That's why I'm asking whether on the drug you are getting, or once in a while on the drug. That makes a little sense.
In absolute sense, you want a total urticarial free.
It's not possible.
It's like getting PASI 75, 90 or 100.
So I'll just take one because we have very limited time left. First, Sushil sir, just one point. Any particular antihistamine you are concerned with the cardiac safety?
Literature says desfluradatin is the best for cardiac safety simply because even if you increase 9 times the dose, whoever is interested to increase the dose, the cardiotoxicity is not seen. This is written in Wolverton, not my words.
Same, sir. I mean, most of the drugs are very cardiac safety, at least even of the updose. Similar like 9-fold elevation data is also there with fexofenadine also. They have a 9-fold elevation data which is published way back in 1992 or 3. That also shows a very high cardiac safety. So I think most of the drugs are very safe, especially the second generation antihistaminic. But still, there can be some role of first generation antihistaminic, and Indian guidelines suggest first generation antihistaminic can be used in case-to-case basis wherever we feel. So Ashit said, do you still use first generation antihistamine in some of the patients? And if you use, where and how long?
Yeah, I do use, and one of my favorite is doxepin, you see. Doxepin 25 milligram or 10 milligram at bedtime. It's a great antihistamine, and it works where some of the other drugs do not. So I do use first generation antihistamine depending upon the situation. As Dr. Inamdar said or Dr. Sushil said, there can't be absolute. So you just have to look at your patient. My drug of choice for first generation antihistamine, besides in pregnancy where we use chlorpheniramine in first trimester, is usually doxepin or hydroxyzine. Doxepin, I'm very happy. And you have to be slightly careful with doxepin when you are using it for cardiac patient. Although we use it in a relatively low dose, 10 to 25 milligram, but in a dose about 25, 50 milligram or 75, there could be some cardiac issues. So, but I'm happy with 25 milligram. There are only situations just a few situations where I've gone up to 50. But doxepin is a great drug in my hands, and usually in others' hand as well.
So that is an interesting learning point. Yes,
No,
sir.
One general thing about the first generation antihistaminic. When you want to use it in elderly patients, urinary retention and the glaucoma.
That is very important. That is very important. So elderly patient, we need to be very careful. We should not be using for long duration. It should be up to 3 months. That's how the recommendation comes. Doxepin can be especially used in a group of patients where there is a lot of psychiatric morbidity associated. Those things are the people who possibly respond better with doxepin. And hydroxygen can be used less than 6 months age of children, because that's how the licensing is there, and that's how the Nelson pediatric textbook suggests that below 6 months hydroxygen can be used as a drug. Though there's no logic if you can use hydroxygen, why you cannot use levocetirizine, but still that's how the recommendation came from Nelson textbooks of pediatrics in general. So these are the circumstances where first generation antihistamines can still be used in spite of second generation antihistamine being possibly the most important for 99% of patients. Sushil sir, yes.
Yeah, just one point. One is that, one more molecule I find useful is mirtazapine. Mirtazapine works well, and even that has an anti-anxiety role in people who come with neurotic excoriations along with urticaria. They've wounded the skin. And regarding hydroxyzine, I just had an interesting case of an infant who was brought somnolent with altered sensorium. And this is a case reported by Dr. Deepak Parekh. And an infant who was given hydroxyzine, and it had caused so much CNS sedation that patient was hospitalized. Respiratory suppression had happened. Respiratory center had also got suppressed.
That is very important, because this first generation antihistamine can cross the blood-brain barrier, and that's why it can generate a lot of unwanted side effects. So we need to be extremely careful using the drugs. We need to stick to the proper doses, and of course we cannot updose first generation antihistamine. That's something we need to keep in mind.
I think just one more point, if you give me the space.
Please, sir.
I think paradoxical hyperexcitability, paradoxical convulsions too have been reported with antihistamine. So you need to be careful when you use first generation, particularly in young children and infants.
Yes, sir. Yes, sir. That's also cognitive impairment. Those are the things we need to keeping in mind. And there are restlessness among the children, which has also been seen. School-going children's performance has been decreased with first generation antihistamine. So in general, we tend to avoid first generation antihistamine, we are more prone to use second generation antihistamine. But there are certain selective situations where you can still possibly use first generation antihistamine where we do not have any better alternative. I will not take much more time, but I just want to talk about since Madam hasn't used in updosing, Sushil sir has used, Ashit sir has used. Do you think the sedations, even to bilastine or fexofenadine, happens when we actually updose?
Yeah, it can happen in a few people. We cannot tell them it's totally non-sedating. It can happen in a few people.
Yeah, agree.
So that is can be present. Sedation can be present as a symptom, though it's usually mild in where we updose those patients. So we need to be careful, and especially people who are like pilots and all those people, we may not updose those drugs. So these things we need to be keeping in mind. Just one liner, sir. Levocetirizine, fexofenadine, or bilastine, which is now your choice of start of second generation antihistamine? One liner from each of you. Arun sir.
Levo first, then bilastine, then the fexofenadine.
Sushil sir.
In naive cases, bilastine, but those who don't respond with updose, I sometimes switch to the levocetirizine. But in treatment naive cases, bilastine. Only I have to remember to tell them to take it on empty stomach, because if they don't follow it, then the absorption can be down by at least 40%. It takes 3 to 4 days for the blood levels to match. After that, whether you take it with or without food, it doesn't matter. But initially, for a good response, they have to take it on empty stomach.
Bella madam.
I use a lot of disloratadine, then levocetirizine, and then bilastine.
Ashit sir.
Levocetirizine is first choice. I found fexofenadine absolutely free of sedation most of the time. So when sedation is an issue, fexofenadine. Levocetirizine, fexofenadine, bilastine.
Thank you. Thank you. Bilastine has been used for chronic urticaria, we know. But have you ever used bilastine for other dermatological pruritus? Anybody? Does it work?
No, it doesn't work. Doesn't work. I will stick my neck out and say it doesn't work.
Bella ma'am?
It has
Anybody
worked
else?
for eczema patients. It has worked for eczema patients.
So in eczema, you often use other things to suppress eczema. So it's very difficult to say what exactly.
Arun sir wanted to tell something. Arun sir?
That it is the drug developed for the allergic conjunctivitis and all in Japan first, actually. So in fact, it has got a better antipruritic effect, they say. What I would, with that an idea, if the patient is having a history of atopy, this drug would be more better than, for example, earlier people used to use, or nowadays also, some people use the combinations are also available, montelukast. Instead of montelukast, probably this would be a better molecule if there is a history of atopy with other manifestation. It may work better.
Having interest in pruritus as such, I have used it in a lot of non-articulated pruritic conditions. And I mean, so far my experience is that it doesn't really.
So possibly higher selectivity of the receptors also makes it clear that non-histamine causes of itching may not be that much.
Most of chronic pruritus is non-histaminergic. I would consider bilastine is just another kind of antihistamine. That's all.
Okay.
Sir, Ashit sir, beyond omalizumab, some of the patient also doesn't respond well to omalizumab. Now we are knowing at least 20% patient has this type 2B autoimmunity. So beyond omalizumab, any other drug you have used, any other biologics you have used for the management of urticaria?
You not use, but dupilumab can be used.
Dupilumab, yes, but is it available in India? Is it?
It's available.
It's available at 57,000 rupees for one vial.
That is a different question.
Yes, 57,000 rupees for a vial. So if you use 3 vials in the first 1 month, it comes to 1,71,000.
And if you have to pay from your own pocket, then you will develop so many other diseases.
Yes, you have to pay from your pocket only.
There are first 13 patients of dupilumab we have sent for publication. Me and Dr. Sandipandar has sent for publication for dupilumab. Of course, for atopic dermatitis, not for chronic spontaneous urticaria. And rituximab. Rituximab is freely available everywhere. It's cheap and it's available in most of the government medical colleges. Rituximab now showing good data for refractory cases of chronic urticaria. So sometimes we may try that also.
I'm worried we're using rituximab for such indications because of the persistent immunosuppression which can last for up to 1 year.
That is important, of course. Of course.
Yeah, with omalizumab, it's okay because it's not in true sense an immunosuppressive. It just hits IgE, so that's fine.
Ligelizumab is also on the pipeline. Some of the some of the centers are working on the phase 3 trial, so possibly we get the data very soon. Can bilastine be used in combination with other drugs like omalizumab or cyclosporine?
Of course.
Of course, yes.
Yeah.
Recently, there was another biologic IL-5 antagonist. I read in New England Journal of Medicine somewhere.
Yes.
Worked extremely well for urticaria. One shot gave about 3-4 months remission.
So they have two types of IL-5 inhibitor. They are direct IL-5 inhibitor, also IL-5 receptor inhibitor.
Yeah,
so
it's
both are
IL-5
working
receptor
very
inhibitor.
well. Then there is another group of drug which is called glutathione kinase inhibitor. That is very interesting because it works inside the mast cell. So it seems to work on all types of urticaria, arterial, vascular, whatever mast cell is working. Glutathione kinase inhibitor can be is a very interesting drug.
Whether we are able to use biologics or not, but it does one thing, it tells us more about the pathophysiology of the disease.
Pathogenesis, definitely. That is very important.
I just want to ask one question, if you permit me. With omalizumab, they say children with atopy and respiratory allergies, if they suffer from viral infection caused by human rhinovirus, the duration of the infection goes down and the overall prognosis is better. So it is an antiviral property also. So do we theoretically expect some benefits using it in SARS-2 COVID-19?
Food for thought.
Interesting. Good thought. We don't know for sure. There are certain
Dr. Namdar,
questions.
yes.
Sir, you are muted, sir. I need to take some questions now. Does diet play any role in urticaria? Bella, madam, please sum up.
Oh, that's pseudo-allergens do play a role in urticaria, so that should be avoided.
And maybe in acute urticaria also there can be some role of diet, but how chronic urticaria?
Not in chronic.
Hardly any.
Yeah.
There's another question: use of H2 blockers, ranitidine in urticaria. Shushil, sir?
I don't think it works in my experience, but when a patients complain of acidity and they tell you
2009 guidelines, it was
correct.
part of 2009 guidelines.
So it doesn't work, but when my patients complain of acidity and they don't want me to write less drugs, I tell them you combine with this and it may have some questionable benefit and your acidity will go down. A lot of patients have an allergy to whatever you write. They say, doctor, it should not cause any acidity or medicine.
Dr. Niranjan from Nagpur is asking, patient can take bilastine if he is taking diltiazem? Ashit, sir?
Yeah, I think it has no specific drug interaction, so it should be okay. I'm not very sure.
Erythromycin, diltiazem has drug interaction with bilastine. Can increase the So these two drugs have interaction.
Okay.
You can give, but do not updose in these patients.
Okay.
But that was more for tafenidine and estimazole, which were withdrawn.
Yeah.
That's where the reactions were more.
Dr. Akhil has a comment that doxepin is a tricyclic antidepressant. Yes, but it also has an antihistaminic action.
Yeah.
That's why it should be used. If you remember, the discovery of antihistaminic is actually came from the antidepressant and anticholinergic only. Boved once started acetylcholine molecule, then all those byproducts we have found that antihistaminic and the anticholinergic and antidepressant. So all of them have similar sort of molecule, and that's why some of them has a overlapping functions.
Doxepin has anti-H1, anti-H2 both, along with antidepressant.
H1 antihistamine action is said to be 760 times more than of diphenhydramine, which is said to be the gold standard for antihistamine action. So doxepin is a great antihistamine. And the dose where we use, probably we use more as antihistamine than as antidepressant, of course.
Dr. Subhas, Arun sir, the question for you, polaramine 2 mg can be used once daily, 1 to 2 years, once daily for adults in urticaria. I think he's a comment more than a question. Can we use 2 mg polaramine 1 to 2 times for 1 to 2 years? Can it be safe to use polaramine for that long duration, Arun sir?
No. If that with that dose, if the patient is happy, I don't think it should not be used unless well, the patient has any comorbid conditions, especially being the first generation antihistaminic, probably cardiac things should be evaluated. I don't say give something like take for 1 year. Usually I see after 3 months, at least I will tell them sensitize, okay, you have to take for 3 months. Then
So that's the point that
still that takes 6 months, like that. And then probably we nowadays we have got omalizumab and other cyclosporin is an option. Earlier when we were as a student or my seniors who are there also, like chronic urticaria, okay, lete jao anti-histaminic. But now we can actually make some real change in their approach rather.
So that's the point, that fast generation antihistamine should be rarely used, and if used, should not be more than 3 months at a stretch. So that is coming from our panel. With this, I think over to you, Dr. Gaurav.
Thank you, sir. Thank you for moderating such a wonderful panel discussion. And I would like to thank all the panel members also for sharing their views and their experience on various aspects of management of patients with urticaria, especially during the COVID era. Now, I would request Mr. Parikshit, who is the General Manager, Vessel Specialty Division, to share vote of thanks. Over to you, Parikshit.
Yeah, thank you, Dr. Gaurav. First and foremost, I would like to thank Dr. Abhishek Beg for moderating such a wonderful session, and also taking time out of a busy schedule, because right now there is another meeting going on for IDVL, which I think most of you would be going. So I earnestly thank all the panel members, Dr. Bela Shah, Dr. Sushil Tailiani, Dr. Arun Inamdar, and Dr. Asit Mittal, and Dr. Anil Ganji, who was there with us for some time, for taking time out of a Sunday afternoon of a busy schedule and agreeing to be part of this wonderful webinar. I'm sure that the insights that we have generated with the two presentations regarding Bilastin use in chronic spontaneous urticaria, as well as the general discussion that we have had over management of urticaria during COVID times, will help us tremendously. And these insights can be used further to our use. And at the same time, the doctors who have attended this webinar also would have found it very satisfactory and very informative. So once again, from Glenmark, we always endeavor to bring the latest in urticaria management and other therapies to the dermatology forum in a big way. And this particular web series keeps on continuing from our side. And we are sure and thankful for all the esteemed panelists and the KOLs for agreeing to be part and always associating with Glenmark in the most positive way. So once again, thank you from Glenmark. Looking forward to meeting you soon face to face, because now with the curve flattening and hopefully things coming back to normal, soon we'll be able to meet and have meetings other than the online sessions that we are having. So once again, thank you very much, and good evening.
Thank you, Abhishek, Asit, Dr. Sushil, and everybody.
Thank you, everybody.
Thank you. And with the European experience, we should take the curve flattening a bit too carefully.
Yeah.
Yes.
It flattens.
Slightly premature, yeah.
Thank you, everyone. Thanks a lot for joining.
Thank you.
Thanks.
Thank you.